Okay.
Hi, good morning.
Good morning. Hello, Silvia, my best friend since forever. You should all know that. And I can't even tell you how many years we've known each other because you were a dog groomer in the first clinic I ever worked at. That's when we met each other in Spain.
Yes,
And
yes.
now you are, do you want to say exactly what it is you do now? Because it keeps changing.
Yeah, so now I'm the infant feeding team for the neonatal unit in a NHS trust
In Liverpool.
in Liverpool, yeah. I work at the Liverpool Women's Hospital.
And you always tell me all these amazing tales that I'm like, I don't know how you can do this with these little teeny babies that just fit in your hand. And I think because we think our job is hard, like when people get upset because their cat dies, but I cannot even fathom how you guys deal with babies that are sick and parents, maybe they've been through the whole IVF treatment forever, and now this
Yeah,
this pregnancy is not going as wanted, and something happens. And so the reason we're meeting today, right, and we decided to turn into a podcast episode is because I wrote a post about when there's a lot happening and we don't have enough staff, how we have to accept that it's never going to be an ideal world and we just have to do whatever we can, right? And you reached out and said that you also have like often several emergencies at the same time and you have to deal with like baby and parents and all these things. So you had some suggestions that that might be inspiring for everybody listening in the veterinary world.
yeah. So we are an emergency service. We are a neonatal intensive care unit. So whatever comes through the door, most of the time we don't expect it and we don't know. So one of the things that we do in the morning is a little handover. If we know something is coming, sometimes we have a heads up. So, delivery suite will come to us and say, hey, we have a mom that she's 25 weeks pregnant, but she's in labor or she's going to be in labor soon. So we more or less, we know that, that mom, we can expect it maybe during the next few days that she's going to deliver. Sometimes it's just a crash call downstairs. We have a mom in the parking that is giving birth, and then you have to run because you don't know how many weeks she is, you don't know the conditions. We have had babies that they were born literally in the toilet because mom thought that she needed to go to the toilet, but she was in labor and the baby fell down the toilet. I mean, we have all sorts of emergencies, and because we are a big unit, so every time we go to work is probably about 20-25 nurses on shift. We have probably about between 40-45 cots. So that is about that number of babies that they are
Oh my
needing
God.
or help. And again, you may have one emergency, non-emergencies in that shift, or you may have 5 admissions, and then you have to share your resources the best way that you can. So with the morning handover, we say which room is going to be the next admission, which nurse is going to have the next admission. So we have everything ready. So we have setups already for the basic stuff that we are going to need when a baby comes over. In every room, we have resource trolleys. So the resource trolleys, they are really, really handy. You don't use them as a storage resource. So if you need something during your shift, you should go to the storage room. You don't use the resource trolley. So the resource trolley is always available. And we put what is called I can't remember. Anyway, it's like they are locked. So unless that you open them because you need them, they are always locked to make sure no one touches and you have everything there ready to go. On the top of the resource trolleys, we have all the instructions on what to do, whatever you need to do. So if you need to do full resource, you have all the doses, the drugs that you are going to use, the order that you are going to use them. That saves a lot of time. And when you have a mixed skill, because when we have in the rooms, we always have like a very senior nurse, someone that has been there for a couple of years, and usually you have a third person that is very junior. So the idea is that the instructions are clear enough for a junior nurse to be able to follow everything, isn't it? We have a lot of guidelines that I think is the most handy thing that you can have, because our staff changes every 6 months. So every 6 months we recruit nurses and we have junior doctors coming in. Usually, nurses, they know more than doctors in the way that, doctors, they know all
I
the
know what you mean.
medical
I know
stuff,
what you mean, though.
all the
Yeah,
medical
yeah.
stuff. But nurses, we do this every time, all the time. So, when it comes, I don't know, to change ET tube, or we need to do resource, or we need anything that we need to know, everything is on the guidelines. And even if, even if you don't feel like, oh my God, what should I do now? You just go to the guidelines and then check on them. We have it's a really cool app. It's called Iola's app, and it's free for all healthcare teams. So probably you, even if you are a vet, probably you could use it. It's free, and you can you can put everything there. So we have from policies and guidelines to leaflets for parents. They just need to scan a QR, and they have the leaflet in the phones. So it's very useful, I imagine, for you guys if you are going to do consents, or information about what's going to happen after surgery, or what is the, things like this. They are very useful.
That sounds, it
Um,
could be a good inspiration. Maybe you can send me the link and then I'll put
yeah,
it in
I'll
the
send
show
you the
notes
link
afterwards.
later. Yeah.
Okay, cool.
Um, Emergency leaders. So when there is an emergency in any of our rooms, there is always someone who is going to be the leader. And I think it's important to know that not always the medical staff is going to be leading the emergency. Most of the time is a nurse, because we know everything. Not everything that we know everything. I mean,
Almost,
some people
almost.
is born to be a leader. And
Yeah.
they are very bossy and they have everything very clear, and they will be saying, okay, so doctor is going to be intubating the baby. You nurse A, you are going to speak with the parents and keep them updated. Nurse B, do start the drugs. Nurse C, double check the drugs with, so they have everything very, very clear. And I think that is really good if you in your teams can identify who is the leader, because if you know that, that is going to simplify and make everything smoother during an emergency.
I can
Um,
definitely see, and it's just not during an emergency, because when I've seen there's no clear lead in a
yes,
clinic, everything just slows down. It just gets stunted. Like people are running around not knowing what to do. You can have a lot of
yes,
people, but you get less done. I find sometimes on nights when it's just me and one nurse and a kennel assistant, we get more done than maybe a Dane team could do in the same time, because we just yeah, I'm obviously the leader. It's just like I'm the senior vet in charge. So, and we just quickly get things done. But when everybody are waiting around for someone else to do something, that's when you have a problem.
yeah. And I
Yeah.
think not because I'm an ass, but I think in the case of vets, you should have a strong big team of nurses, because they are going to get you loads done from your workloads. You can delegate a lot, and there are a lot of things that they can do. And even if you have two emergencies, say, I don't know, you are in the middle of a surgery and through the door something comes and need resource, a nurse still can do a lot with that. And you can still be shouting from theater saying, okay, start with adrenaline. But if you have this guideline already, they can start doing things still under your supervision, because you know that everything is there. But you don't need to leave theater, that probably, that is still, maybe it's a routine operation, maybe it's not. But if you can put your mind at ease, because that nurses, they are, starting getting things going on. And maybe, if you are with another vet doing the surgery, maybe you can say, okay, now I can do this on my own, just clean yourself up and change roles and go back to attend that emergency. I think nurses here play a really, really, really big job. I mean, as I said, usually we are 20-25 nurses per shift. Probably doctors, we may have two consultants for the whole unit. And then
Wow.
we have advanced nurse practitioners. They are something in between a senior nurse and a doctor. So they can still do a lot of things like intubating babies, making changes in the medical plans. They do a lot. So, doctors, we don't have as many, but nurses, we are a massive, massive, massive team. Um,
What do
So
you think? Because you have worked in a veterinary clinic as well, so you've seen
yes,
both sides. I've only seen obviously the vet world, but
yeah,
I get a feeling that vets are not that good at delegating. So I have learned now through, I have learned now to delegate. I feel
yeah,
like I'm good at it and it's amazing. And it just makes you realize how good people are at their jobs. No, instead
yeah.
of just sweeping the floors, place a catheter, for example, in vet med. No. But what do you think is the difference between the doctors, why are they so good at delegating compared to
I
vets?
think
Why do
it's
you
because we
think?
have the capability of doing things. I think veterinary nurses and vet technicians, for the ones in the States, they are very limited because of the law. I think
Mm,
at the end is the vet's responsibility, what you can delegate and what you can feel that you can't. So I'm not sure about how is the law in here. No, in Spain, for example, we are not allowed to intubate a baby, to intubate a dog or a cat, or I've done things with you because
mm,
you teach me, you taught me, and I was able. But if something happened to that dog that day on that surgery, it would be your pin
mm,
in the game, really. And
yeah.
when you have to debrief and you have to go to the Royal College of Surgeons and you expose your case, and you will have to say, because we have a duty of candor, and you will say to your in the Royal College, you will say, well, indeed it was my vet nurse who intubated that day. you know
Mm,
at the end of the day, you are responsible. So I think people is still very, very aware of what can I delegate and what I can't. So maybe it would be good to bring all these conversations on the table and push for the Royal College of Veterinary Surgeons and say, hey, can you describe clearly what things nurses can do, what they can't do, or what is up to us, you know? And depending on that, maybe just again reassign jobs for the nurses and say, okay, let's sit down, who wants to do this, who feels confident to do this, because again, you will have nurses that they don't feel confident doing certain things, and others that they feel like, okay, just give me more because I love
yeah.
it.
So maybe
So
we are a question of like, so first of all, because I think the guidelines are probably there. I think maybe just we don't, a lot of people are not, I sometimes have to ask the kennel assistants, for example, are you allowed, can you do that? Are you allowed to do
yeah,
it? I don't want to
yeah,
ask you to do something. So I, for example, I kind of trust that the nurses know what they know, what they can or cannot do. But maybe like you say, it's sitting down as a team, no, as a leader and say, okay, so let's just make a list of, just so you know, the nurses can do this. And the nurses that are not confident doing it, how can they get confidence? So who do we need
yeah,
to train a bit more and maybe push that a bit? But on top of that, I've also, when I coach vets, I find that they tend to say, I can do it myself faster. I can do it myself quicker. It's quicker to do it myself than ask. No, like I think a lot of vets tend to just want to do it themselves because they
yeah.
don't have the patience for it. No.
I think it's also been that your job, guys, it's been a very lonely job for many years. I think the image of having a helper or a nurse or a support worker with you, it's been always been delegated to cleaning, to help you with the admin jobs, or I know in the UK the nurse is an older job, but in Spain, for example, it's a very brand new job. I mean, if you look 30 years ago, it was just the vet doing everything in the clinic, isn't it?
Yeah.
So trying to change also that mentality that it's not, you don't need to do everything. Um,
Yeah.
is changing
Remembering
that.
that. Yeah.
Yeah. And I would also say try to invest in nurses. So my job is a specialist job. So I still do clinical shifts, although, I'm not going to do many more now because I'm taking over the infant feeding lead for maternity too. But my job is very, very specific. And we have different teams. So we have a team that is infection control nurses. We have a team that does clinical governance. So these are the kind of nurses that will review all the incident reports that they come on shift. They look on how to improve services, etc. Then I do infant feeding. There is another team that does bereavement. So they're in charge of, what happens with when a baby passed away, and they support both teams. So they support nurses and they support the parents. We have another team, it's called FICare, it's Family Integrated Care. So when parents come to the hospital, it's not everything about the baby. We try to get the parents as involved in the medical decisions and the care of the baby as much as we can, because we have seen that it reduces the risk of depression and many other things. But if there are siblings, we look after the siblings too. So for Christmas, we have done like a Father Christmas grotto, and we do like Lego days. So we put Lego. Like little figures of Legos everywhere in the unit, and the siblings, they have to find them, like a haunted thing. So we do a lot of things. And that also encourages to the nurses to stay in our team because they love it. They feel empowered, they can do a lot of things, they can promote many things, they can bring new ideas. They go into the specialist role that they like. Obviously, you will have the nurses that they just want to go to work, get everything done, go home and forget about it. But then you have the ones that they want to do something else because, doing every day the same thing is for me, at the end of the day, is boring. So I always need to do something else. But investing in nurses is a really good option. And not everything has to be paid. I know some clinics and hospitals in the UK, they offer, it's like an incentive, and they will offer, I don't know, like £50 per year for trainings and stuff. There are a lot of things that they are free. I'm a really good, I love education. I do a lot of teaching. And I'm always finding like free webinar about I don't know what, and then free another webinar, or free conference, or everything that I say. And because in English you find so many things, in Spanish is more limited, but in English you find loads. So I'm always sending things to my link nurses. So I've got a small team. So it's me and another 3 nurses, but then I've got 15 link nurses. So they don't play like an active role, but it's very handy if you are not on shift and no one from the infant feeding team is on shift. Link nurses, sometimes they can help. So, if there is a mom that needs to be seen because she's struggling with breastfeeding, then, you can tell them, oh, do you have 10 minutes, and go pop in and see this mom. And they love that. I think the other good thing is that we need to acknowledge that we don't know everything, many, many times, because I'm the specialist. They come to me, and Silvia, they present the nurse presents me, introduce me to the parents, and they are like, oh, she knows everything. And it's like, no, I don't.
Oh God, no pressure, Silvia.
Yeah. I mean, I'm good at my job, but I don't know everything. There are loads of things, that you are learning every day. I mean, indeed, yesterday I was listening to a podcast about, it's another couple of lactation consultants, no? And they were talking about tandem feeding when, you are still breastfeeding a toddler and then you get pregnant, no? Well, and she was saying, no, that if you get pregnant and your baby that you are breastfeeding is still below 6 months, probably you will need to give supplements because, the milk changes. Anyway, so there is always things that you are going to be learning. And especially when you work in healthcare, everything progresses, changes, so it's okay not to know everything. That's what I want to
Tell
do.
me, because I think that's a big one for vets. No, tell me how you deal then with that. Like, you just accept I don't know everything, and then
Yeah,
you go
yeah.
on with that. You just accept it,
You
right?
accept it. I mean, there are some times that you go to a case, I had a few weeks ago a case that it was a baby that had been establishing breastfeeding for like 6 weeks. It was a preterm baby. It was now near 10 baby, looking at going home, and the baby wouldn't latch. I mean, he was interested on the breast. He would smell the breast, he would latch and then fell asleep or just pulling the breast. And I had tried everything in my single, I mean, I tried everything, and that baby wouldn't latch. And, the only thing that was keeping that baby in the hospital, it was because he wasn't feeding. So the only thing I could think of, I was like, has the occupational therapist seen this baby? And the mom was like, no. And I was like, this is my last chance. I can't think of anything else. I'll tell her to come and have a look at it. So she came and she observed the baby and she thought the baby was a bit disorganized, no? So the time that baby was going to latch on the breast, baby was a bit like this. And she thought that
Flailing.
was the problem. So she said, okay, let's just half wrap the baby, just, wrap the arms so the baby's more contained and see how it goes. Hey ho, that was the thing. That was the baby did. It started to fit, went home. So yes, sometimes you don't know everything. Many times I will come and I'll say, you know what? I don't know. I think it could be this and this and this. Sometimes it's just time. You want to rush things, but it's up to the baby if they are ready or they are not ready. And if I don't know anything or what's going on at that time, I'm just honest with the parents, and it's like I don't know. Is it okay if I speak with other colleagues from from the area and see what they think? And most of the time they're quite open and say, oh yeah, that's fine. No, because usually I have to take pictures or videos or comment the cases. Um, and sometimes it's just a bit of networking and asking other colleagues, hey, I've got this case. Have you had something similar? What did you do? Did it work? Or things that they didn't work. Sometimes it's within the colleagues. They ask you something and ask, a question out of the blue that they think of. And you think, you know what? I don't know the answer, but leave it with me. I'm going to do a bit of research, see what I find, and I'll get back to you when I know.
Mm.
So I mean, it's impossible to know everything.
I think a lot of vets especially put that pressure on themselves, and and I think it's even harder for us because we have so many different species, right? And it's like you
Mm.
have a cat, you have a dog, and then you have the different ages, because at least you're dealing with babies only. You don't have a 90-year-old and a 9 months old and have to know
Yeah,
everything about both, right? So it's a bit different. Tell me a bit
it's
about
trouble.
your tell me a bit about your the bereavement team. How do you deal? Because that is something that happens with us. When there is it's a failure, quote unquote, or there is a death, something
Yeah.
happens. I've had a few lately in my hospital that was after a C-section. We had
Okay.
a dog that died that just didn't recover, and then we had a sudden death after a spay. The bitch just died 2 days later for no reason. I did the postmortem and it looked like a heart attack. And you have these deaths that you think, oh damn, this shouldn't have happened. And how do you deal with you? Because I can't, I mean, these are dogs, and as
Yeah,
much as I love animals, I cannot imagine compared with a baby. Like, how do you deal with that?
it's a tough one because we have many deaths. I mean, we are an
Wow.
emergency service, so we are probably talking about maybe between 40 and 50 deaths per year. So I mean, it's a high number, but we are a reference hospital. I mean, we receive babies from everywhere. Um, so we get babies from Isle of Man, babies even from London. It depends if the other units they are full, they will send them to us. So we have babies from everywhere, and we admit babies from week 22. So 22 weeks is pretty much half the pregnancy. A
Jesus.
full pregnancy is 40 weeks, isn't it? So
How how
22,
much do how much do they weigh at 22 weeks?
oof, 400 grams.
Oh shit.
Yeah, they're very
Okay.
little, very, very little.
Yeah.
Um, so when you have babies that they are this little, you talk to parents and you try to prepare them that the outcome is very, very uncertain. It may go both ways. Then you have babies, that they are older and the parents think, oh, because they are older, they will do better. And it's not always the case. So with bereavement, I think it's a lot of, so the families that they come to us, they don't have memories of these babies. So it's, it's kind of easier to grieve an older kid or a person that you have a lot of memories with. But a baby that is just been born, there are no memories. You have only memories from when the baby was in. And for the dad, not even that, because that dad hasn't had time to bond with the baby at all. So we have to make the memories. So anything that has been used by the baby will keep in. So we have a memory boxes. And then in these memory boxes, we save everything. We keep ECG leads. I don't know, the clamp that we were using for the ETT tube, the cord. Usually, most of these babies, they don't have we don't clamp the cord because we use it to do long lines. These babies, the veins, they are tiny, so we need to use the vessels from the cord. So these moms usually they don't have even that. Anything that is being used by the baby, we put it on the keepsake box. Then when the baby passed away, we do a lot of again memory making. So we use what is called what do you say escayola in English?
You got me now. A cast?
Yeah,
like you
so
make
we
a cast
do
stuff?
like hand cast, like feet cast, so they can take something home that they can touch, and it remembers really the baby. They can say this was my baby's feet or my baby's hand. We can take hair if there is any, because usually when they are so little, there is no hair. We record the heartbeats and then we put it inside of a teddy. So when they take the teddy home, they can press the heartbeat and it's the heartbeat of the baby.
Oh, wow.
We have like digital diaries. So in our digital system, when we record all the clinical data, we have something that is a baby's diary. So every time that we are on shift, we take pictures of the baby, whatever they are doing. It could be something like, I've been super brave today, my ET tube wasn't working, and my nurse changed it. I didn't misbehave.
Oh.
It was easy peasy challenge completed, no? We do a lot of all these things. So again, after whether it's a bereavement or the baby has been discharged, we download everything in a USB and we give it to the parents as a memory. But also it's very nice because the rest of the family, if they can't come to hospital, they can follow up what's going on with the baby. So that's something else that we do. For staff, we do a lot of debriefs. I think debriefs are essential. It can happen that you are the most senior nurse in the week, that week, or for the, like in the month. And because you've been the most experienced, you keep one baby after another that they are very sick. And this is energy draining for a nurse. It doesn't matter how much experience you have. It doesn't matter how good are you at your job, and it doesn't matter how many deaths you have seen. It's emotionally draining to look after sick babies that they are dying one after the other one because they come in waves too. So it's like I always say, we have twins. When one set of twin comes, it's like one after the other one. And you think, what did they put in the water for everyone getting pregnant with twins? So we on the debriefs they are not to say, it's not to talk about what what went wrong with the case for the baby to die. That is a different thing. We do like emotional debriefs.
Right.
Usually it's one of the consultants who leads on that. But everyone is welcome to them. So it could be just the one nurse that look after 3 hours after the baby, or it could be the nurse that has been looking after the baby for several days or several weeks. But it's about talking of feelings or emotions, how can we help you with this? Is there any support that I can give you? I don't know, it could be to say, okay, do you need a break and do you need to move, to a different area where you don't see deaths for a while? We'll put you with babies that they are more stable. Try to make accommodations for the staff so they feel like they can come to work the following day. And these are quite useful. Sometimes they are like in person, sometimes most of the time we also do it on Teams because not everyone is on shift when you do
And do people open up then? Do they open up? Because
they
that's
do,
one thing
yeah.
in the veterinary world. I think people really struggle with being vulnerable and telling. Like people keep their cards very close to their chest, and they'll
But
be like,
yeah,
"No, I'm fine." So how do they? What do you think
but
that?
I think it's because they go with the fear I'm going to be blamed for the death of the animal. You know,
Yeah.
is this is about feelings. You don't talk about why you did. I don't know.
Yeah.
Is this late, or why did you,
Yeah.
it's not to blame people, it's just to talk about feelings. How did you feel? And how can we make things better next time? So, we introduced something, it's called like well-being weeks. So every team, because we are like 250 nurses on the neonatal unit, we are divided by teams, no? So we have like purple team and yellow team and orange team. So every team, every week or every month, does a well-being week and is themed, So sometimes it's like a spa day, and then you bring anything that you have home, that it could make the space like a spa. So you will, we bring like eye mask, and someone else will bring a foot massager, and someone else, oh, I know how to do aromatherapy. I'll bring candles, and so you bring things to the staff room, and then during the day, you make sure that everyone has a break and can enjoy the well-being stuff that we have put there. Um, we do a lot of, I don't know, baking and cooking, because food always cheers people up, isn't it? So
It
we
does.
do like NICU bake off. And I don't know, it's just things, to bring people up.
Do you feel ever, because I feel sometimes working in corporate, are you okay for time still? Just tell me when,
Yeah.
yeah.
I've got until 11. Yeah.
Okay, that's fine. So I feel like sometimes in corporate, it just feels very forced. It's a bit like there's something lacking, like there's not real support. We don't have real discussions, but then over here now you have free pizzas. I feel like,
Okay.
does it ever feel like that in the NHS? Does it feel like they're just kind of putting band-aids on these big wounds that are never addressed?
In many teams, it feels like that. I think our
Mm.
team it's not because it's my team, but we are really good.
Yeah.
So, for example, now I'm taking over a different team, the one in maternity, and that team is not close to each other. There are a lot of frictions. They are very, very down in the feeling that they don't feel supported. They don't get on well with each other. So if you try to put something like flower power there, it's not going to work, because
They're
people is
gonna
not going to
throw it
be,
at you. Yeah.
yeah, people is not going to be engaged. People is going to be saying, why are you giving me this if the support that I need is not this?
Exactly.
They are very, very on the defensive way. And I think the first thing is that you need to try to remove that barrier. Sometimes it comes with new management, sometimes with new ideas. Most of the time, it comes from talking, sitting down with them and say, okay, what do you think is wrong? And what do you think we can do to improve this situation? So this is the first thing that I did with the midwives. It was sitting down, because the main problem with maternity is that mom is the priority and the babies, they don't count in the numbers. So if you have a mom, if you are working on maternity base, for example, in the postnatal ward, one midwife may have up to 12 moms. 12 moms is already a lot. But if you put that 12 moms, they also have one baby each. That is 24 patients. How are you going to look after 24 patients? And how are you going to support feeding 24 babies? Because feeding is not always a straight away. People think that
Mm.
because breastfeeding is the most natural thing in the world, it's going to be easy peasy. No, sometimes if the baby has a difficult birth, that baby is knackered, is exhausted, and they won't feed. You have babies that they are too sleepy. Babies, mom didn't go to any antenatal classes because they were not available, so they are absolutely clueless. They don't know how to pick up the baby. They don't know what to expect from a newborn. So there are a lot of factors there. So when I was speaking with the midwives and I was saying, oh, but you need to look after the babies, and they were like, Silvia, I don't have even time to look after the mom. And, I just do running, blood pressures, and giving painkillers and checking quickly the uterus to be that, she's not going to hemorrhage. I don't have time to sit down with the mom and put the baby on the breast. That is going to take me an hour. And I was like, okay, so the first thing that we maybe need to look at is more staff, or maybe people that only does infant feeding. And a lot of it comes down to sitting down with your staff and say, okay, what do you think is failing? What do you think that is not working? And also ask them for what would you like to do, or what do you think is going to improve, what we can do.
Mm.
Because the other thing is that it's very easy to moan And, many of the staff is like, hey, this is not working. Hey, we don't have this, we don't have that. But they don't give you any solutions. And
Can
you
we just
again,
agree that is a very, very common thing in Britain as well? I think that's the British thing. We can moan, yeah. They moan.
I always say, okay, that's fine. Come to me with a problem, but give me a solution too. You
Yeah,
know, because usually the people who moans, usually they know what they would do to, to make
true.
it better. Maybe not solutions, but you may
Yeah.
find things to mitigate what's going on. The other thing that with us works very, very well is reporting incidents. So again, in our unit, there is a really good culture of reporting incidents. Rest of the places I've been, people don't report incidents because they think they are going to be blamed. And what people need to understand is that reporting incidents is to improve the services. So if something is going wrong all the time and I don't know about it, how am I supposed to fix it? I can't.
Mm.
So, it's the same. It's about all that. No moaning all the time, but okay, that's fine. You can moan, but tell me what would you do to improve this?
So you're
And
basically telling me there's two things. No, from the point of the manager, you have to be willing to sit down and
yes.
have uncomfortable conversations and be willing to take the shit. So when they say, well, Sylvia,
Oh
you don't
yeah.
give me this and you don't give me that, and you have to like kind of take it and not get defensive yourself, right? And
Mm.
be open to it. And then you're saying as well that the employees, the people on the floor, if they come and moan, they should think about solutions as well and be able to discuss
Yeah,
it,
yeah,
no?
because at the end of
Yeah.
the day, this is teamwork. I mean, if there is no teamwork and and people is not close together and they are not able to work with each other, it's not gonna work. At the end of the
Mm.
day, people leave. The managers, they are fed up of probably bringing new people all the time, training people all the time, and they leave in 3 months, and then you need to start all over. So managers, they get burnout. The staff gets burnout. People that
Yeah.
they don't leave, not because they don't want, but because they don't have anything else. So they stay there because they have to, not because they enjoy the job. So, I think the first thing to break that is just sitting down and say, okay, let's have a meeting, maybe out of work. We do like away days. So we meet somewhere else, or you meet in work, but you don't come in uniform. You leave the scrubs at home, and you do nice stuff. So everyone brings food from home to share, and then you use these days for this. Like,
Mm.
okay, tell me a list of complaints that you have, things that you don't like how they work, and let's start brainstorming about what everyone can do to improve this.
What do you do though? Because if you have those days, it can feel a bit hopeless. No, because simply you say the midwives that have 12 moms and 12 babies, and it's
Yeah.
like one midwife, and they know there's no money for no more staff. Like you cannot, they kind of already know Sylvia, you cannot offer me a solution. So how do you deal with both their well, I guess them feeling in constant like disgruntled because they can't have what they want and moaning. How do you keep up the spirit of the team when there physically isn't enough staff? How do you deal with that?
Oof. So I don't think even middle management, but for some reason, high management is listening to me now because they have seen the struggles and no, but I mean, you need you need to give something in exchange to people. So in my case, I said, okay, I was speaking with midwives and they were like, Sylvia, we don't have the time to look after these moms. So I said, okay, what about introducing breastfeeding champions? And they were like, oh, no, 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 we have had in the past and it didn't work out. And I was like, why didn't work out? No, because people, they don't get anything in exchange. So it just gives you more jobs to do. In addition to your 12 moms, you are also a breastfeeding champion and people ask you more stuff and they ask you to help out. And I say, okay, that's fine. So I took this to the managers and I say, okay, is there any chance that we can have 1, 2 champions per month or per week? We can give them 2, 3 hours from the rota that they are dedicated only to see moms. They accepted this. They say, okay, that's fine. We can afford that. So
Mm.
hopefully we are going to introduce that. Sometimes it's just introducing small changes that they are not going to make like a super expensive, um, they are not going to add, no? Because, I mean, for example, if they ask me and say, well, but paying for 3 hours is a lot. Okay, but these 3 hours that you are paying for someone to help these moms feed the babies, this is money that you are not going to spend on formula.
Mm,
Because if I get that mom and that baby breastfeeding, I don't need to give formula. I don't need to give top ups. Whether if we are in a hurry, we are spending money in formula, in bottles, in teats, and still I need to sit down with this mom anyway to explain them how to feed. So,
mm,
I think it's a bit of, you sometimes you need to think out of the box and see, okay, how can I help with the resources I have, you know?
yeah,
And I think sometimes, or probably, I don't know, I think because, I mean, I love a guideline and I love a policy, whether before I hated them because it's so much paperwork. And so sometimes it's like you are not allowed to think out of the box because you have to follow the policy, no?
yeah.
But I think because I come from Spain when we have less resources by far, and you just have to think out of the box, saying, okay, what can I do? What would I have? That in here, when you have a challenge, I'm still thinking out of the box, you know. And just reminding also that, a guideline is a guideline. It doesn't mean that you have always to follow everything, by
Mm,
the rules. Sometimes there is, some space to go, on the sides. But yeah, it's, not having a staff and having a massive workload is always a challenge. It's always a
yeah.
challenge. But there are small things like thank you, everyone, after the end of the shift. I don't know if you do it in your work, but for example, we have a shift leader, so it's like a senior person, no, that controls everything that is happening in the unit. She's not clinical, only if she needs to. So if there are 1,000 emergencies, and there is no staff, she will become clinical, but she overlooks the unit. And at the end of the shift, she will come to every single room saying, "Oh, thank you very much for today, for your help and your
Oh,
support."
wow. That
So
I think that does a lot. Just feeling seen and feel
yes,
appreciated. That
yes,
does a lot. No, yeah.
and
I think
acknowledging
people
things.
we need to do that a lot more in
So
vet
that
med.
is a very nice thing,
Mm,
or I don't know, or again, if you are doing the handover in the morning, no, we have like a general handover and then every patient's handover, no, and in the general handover also, but you say maybe, oh, good luck with today. I hope everything, everyone managed all right. I don't know if situations are very, very stressful, we tell them where to approach for help. So, okay, you know that you have, I don't know, we have 2 psychologists in the units, or you can approach occupational health, direct people where they can go to have a safe
mm,
conversation if they need
mm.
to. So that one is also important. And something that I wanted to say, because I mean, we are lucky because we have 2 psychologists on situ, and it's for both, it's for parents and for staff.
Wow.
But obviously, a small clinic, they are not going to be able to have that. But probably you could approach universities, and ask them for students. Would you like, maybe a third, fourth, 5-year student? Would you like a placement in a veterinary clinic where people can go to you and then you can practice your skills or something? Probably universities that will be they would be open to that. And
We
you
have
could,
the vet line. We have vet line as well that people can
okay,
call as well. So we do have something like that. I think people are
okay.
just reluctant to call them. I want to give you, we have 10 minutes left, but I want to give you 5 minutes so you can, pee and have another coffee before your next meeting because I know you're busy
Yeah,
today.
no, that's fine.
But one thing I did want to ask you about, because I remember when we spoke about it in the first time you told me about your job, you told me about how sometimes, and I was just wondering, like, how do you deal with this when you have parents that get really mad and you have to like call security to get them out when you're trying to help the babies? And I think sometimes I see, and I see this getting worse and worse in vet med, where clients are over here and vets are here, and we become each other's enemies somehow.
Yeah.
And that can be, and I see a lot of vets become really bitter and want to leave the profession because now we don't feel appreciated by the pet owners, right? So when you don't feel appreciated by the baby's parents and they are just, working against you, how do you deal with that psychologically? How do you support your team members and yourself as well when you feel you're doing everything and
So
nobody's
unfortunately, we have loads of these parents too.
okay?
And you always try to de-escalate the situation. So loads of empathy and putting them, being in their shoes. I really understand what are you telling me? I really understand what your position is. And if I would be in your place, I would probably the same mad and the same, trying to say, okay, what is your main concern? Is because you don't feel safe? Is because you think I'm a bad bet? Is because what is your main concern? I don't know, maybe they think you are not good enough. Okay, do you want me to stabilize the patient, your dog or your cat or whatever, and try to call another clinic of your choosing, and we can transfer the patient when is more stable? Maybe that is a solution. Sometimes, and most of the time, is that they are scared. They don't know what is happening. They may feel that you don't know what you are doing. And it's not that you don't know what you are doing. Maybe you haven't decided on the plan or the best plan yet. Sometimes I think getting them involved on how to proceed, I think that is a big one. Rather than you saying, okay, I'm going to do this, and this, maybe saying, okay, these are the options. What do you want to do? You will have families that they don't want to decide because they don't want to take that responsibility, and that's fine. If you do a lot of, we have a lot of non-verbal communication, even with the families. So you may say in 3 options, and you can see whether the face is changing. And you can think, okay, they don't want to decide, but that face is telling me they don't like this option. So you can always say, I think the best option is C. Because you saw that when you say C, the face was more happier.
Yeah, no, I get it. Yeah.
So yeah, it really depends with every family. You always try to de-escalate the situation. So,
Yeah, I think what
okay,
you're saying is empathy, having a lot of empathy, a
lots
lot
of
of compassion,
empathy.
and a lot of listening. So not just listen to what they're
Yes.
saying, listen to what they're not saying. And
Yeah.
if you have nurses that maybe have dealt with a couple of angry families now, and I'm saying this, I cannot even imagine if anything happened to any of my babies who are now old, but still. Um, but if you have some parents that have been really negative and have really borne down on you and on your team members, on you saying stuff, and you can feel maybe nurses are talking between them saying, oh my God, parents don't get us, we don't. Do you have that? How do you deal with that?
We have that. We have parents that straight away they say, I don't want my baby to be looked after this mess. And we have to respect that. Loads of apologies, but not because you have done something wrong. Apologies that they are feeling like this and that they've been put on that situation, and that, that things they haven't gone like they wanted to, or apologies if they haven't been listened to. It's this kind of apology that goes with the empathy. It's not because I
Mm,
have done anything wrong, but I'm really sorry that you felt like this with the nurse before.
yeah.
Um, and then trying to make a plan with them. Usually with me, really, really works well. So I had a family the other day, not long ago, that well, they were establishing breastfeeding. There was a language barrier because they didn't speak English, so that was an additional problem. Um, anyway, they were ready for discharge, but the baby hadn't put weight. Sorry, the dog.
He's
Um,
okay.
so the baby hasn't put any weight, and it was nursing fault, okay? Because the baby needs something, it's called fortifier. It's like extra calories that we put on the breast milk. And it was in the wrong, the prescription was wrong. Anyway, this wasn't given. So they were hoping, super happy because they were going home. Then they put baby on the scale, baby then put weights, lost weight, and they were told, no, you can't go home. And this was like the 3rd or 4th incident that week because something else, things that happens. We are not perfect and we make mistakes, and things sometimes they don't go as planned. And sometimes you have one consultant put a plan in place, and then the following day come another consultant with a different point of view, change the plan, So there's always things like this going on. Anyway, so I wasn't working in that room that day, but the nurses came to me because I'm really good with people who complain. So I just went there and I say, oh, hi, my name is Silvia. I've just had a look. I'm one of the infant feeding nurses. I can see how you are upset. I'm really, really sorry that this has happened to you. Let me have a look at the whole picture, why the baby has lost weight, and then we'll put a new plan in place. So I found out what it was the issue. We fixed it. We prescribed we did a new prescription, approached the parents again, and I say, okay, I know that this must be really, really upsetting because you have all your hopes that you were going home today after being here several weeks. I'm going to make sure that I'm putting an incident form. So this will go to the clinical governance team, so everyone will be aware, and then we'll put something, like a mechanism in place so this doesn't happen again to another family. Because most of the time the parents also feel like if this is happening to me, this is going to happen to someone else, and they don't want that. So when you just try, it's just not the empathy, it's that they see that you are making a change and that you really are bothered about what happened. This family didn't shout at me. They were grateful for everything that I was doing for them that day. Where the previous complaints, they were very, very, very rude to all the staff. They were like, no, you are not going to touch my baby. No, I'll do it by myself. So it's a lot of empathy, a lot of apologies for what they've been through. Not because, again, you have done anything wrong. It's just because you
Yeah.
feel sorry that they had to go through that situation and trying to put a plan in place that they are involved. Are you okay if we do this? And then we wait the baby tomorrow and then we'll go from there. And they were like, yeah, it's reasonable. So, and that they see that you make a change and that,
Yeah, I think what you said as well is like you take responsibility. We are taking responsibility for what happened,
yes,
and we are going to look into and make a change. I think people could avoid so many complaints if they just did that. They said, "Oh my God, I'm so sorry your dog died. It was through no
yeah,
specific fault, but we're going to look into it and we're going to do everything we can to prevent it from happening again." I
yeah,
think that would avoid a lot of complaints because I
yeah,
do hear that often when people complain. It's like, we want to make sure this doesn't happen to anybody else.
yeah,
I'm
because
gonna,
at the end of the day, this is
yeah,
what you want. You don't want
yeah,
anyone else going through the same hell that you've been through.
no. Silvia, thank you so much. We've got 2 minutes left before your next
Oh,
meeting. So I
you're
want to
welcome.
please send me that link you said about whatnot
Yes.
information. That would be good for us, and I'll put it
And
in the
then
show
one
notes.
one more thing that I don't know if you do it with your teams or no, but a lot of simulations. It helps a lot because people feel more confident. So we do loads of simulations of babies, the doll is going off, and then you have someone saying on the behind, because it's a doll, obviously, no? And
Yeah.
baby's not breathing, baby's pale, heart rate is very slow. What do you do? Come on, quick, is, but they work really, really well because usually you will have a consultant, a nurse, support worker, someone from admin that was passing by, so having a
Yeah.
good mix, like a skill mix. And also in these simulations, you see who is the leader and who is not.
That's a really good point. So we could do it with stomach torsion. We could running down with a big fluffy dog
Yes.
toy and go like, "That's a stomach torsion," and everybody like, "Who does what?" Does what? Yeah. I'll have to think about that one. Thank you so
Yeah.
much, Sylvia, for
Oh, you're
giving me
welcome.
your
Thank you
time.
for having
So
me.
good to see you, and so funny to speak in English together. It's the first time. Take
Oh, thank
care.
you. See you soon.
Bye. Bye.
Bye.